Is everyone in and settled, you think?
I do.
Can you hear me okay? Oh, good, thank you. I'm Debbie Pearson. I am the new chair of the Wellness Committee, and following Kathy Kelly and all the wonderful things she has done. So pleased to be here and tickled to death that I have a good friend that's smart and agreed to come and talk to us. So this is very exciting. I'm here to introduce Dr. John Bertelson, who started out like many of you. He was an engineer first, a chemical engineer. If you can imagine this man over here that's going to help all our brains, started out as a chemical engineer. And then he decided maybe that wasn't the perfect thing. So I just found out tonight he thought about becoming a vet. But he's allergic to cats, so figured that wouldn't work very well. So he defaulted into becoming a neurologist. So I'm going to tell you the places he went. Undergraduate degree from Rice University, went to medical school at UT Health Science Center in Houston, residency in neurology at Mayo, fellowship in behavioral neurology and neuropsychiatry at Harvard. And then when I met Dr. Bertelson a few years back when he was practicing Plano neurology, he decided that he wasn't quite smart enough. And what he wanted was to be able to take those MRIs and the radiology and the scans and everything, and instead of relying on some radiologist to read it, he wanted to be able to read his own, all of the diagnostics on his own. So while being a neurologist, he went back and got a fellowship in neuroimaging at Dent Neurological Institute. Now he is just a professor. He's a professor at Texas Tech University. He's a professor at the UT Dell Medical Center and has a private practice. We are so very fortunate and grateful that he would carve out and donate his time to all the residents here to help everyone understand a little better about everything dementia. So what we're going to do is let him do his presentation, and afterwards I'll help get a few general questions that you want to ask, and then we'll cut it off because he's got to get home, get packed, and be on a plane at 7 a.m. in the morning. So please join me in welcoming Dr. John Bertelson.
Debbie, that was the kindest introduction I think I've ever had. Many, many thanks. And I've seen some friends here that I haven't seen well, some in 1 decade, some in many, many decades. So it's really an honor and a bit of a surprise of bumping into some faces here that I've known for a long time. And dementia is what I do all day, every day. It's my passion. It's my practice, my profession, and really an honor to be able to speak to the group here tonight. And it's kind of an introductory level. I know there's some physicians out.
Have somebody turn the volume up to your heart.
Yeah. So I don't know a lot of technology. How about if I speak up?
Yeah, that works. Yeah.
There we go. Is this? Now is it on?
Yes.
And I see we go way back. How?
Hold it up close to your mouth.
Real close. Yes. Up your nose.
We'll get it to work.
We like the shirt.
Thank you. It's the Alzheimer's Association shirt and colors. Can you hear in the back?
Yes.
Oh, very good. And I know you can hear in the front. So again, welcome. Thank you, Debbie, for the introduction and the opportunity to speak to this group and talk about something that is a passion of mine clinically. It's something I do all day, every day at UT and at Texas Tech and in my private office as well. So I do need to say I'm on the Speakers Bureau for a couple of medications I'll be talking about, so I'll try not to be biased when I speak about some of the newer treatments that are now available for Alzheimer's disease. And I hit the wrong way. There we go. So I think it might help to start just with some definitions and know what is Alzheimer's and what is dementia. I'm sure Debbie's heard this many times over. I've had families who come in and say, well, my other doctor said it wasn't Alzheimer's, it was just dementia. Or it wasn't dementia, it's just Alzheimer's. Usually it's one and the same. And so I think it's important to know what these terms mean. So dementia is not a disease, dementia is a symptom. Dementia is a symptom that represents any number of diseases that cause a decline in thinking. And the thinking can usually be memory, but it may be language or behavior, personality, navigation around the streets, or planning and problem solving, decision making. So dementia is really, it's an umbrella term that describes a condition that causes these sorts of problems. Now to say someone has dementia requires there to be a functional decline or impairment. In other words, we all, forget a word here and there. We all may get lost driving somewhere that we're not familiar with, but we're talking about a significant decline and impairment, inability to do things that we used to be able to do. That's a requirement to say someone has dementia. And this must be persistent. It's not getting lost one time or missing one bill. We're talking about regular and persistent, constant impairments in one or more of daily activities. And these symptoms can't be in the setting just of an infection. We call this delirium. If someone has a bladder infection and is very confused with that bladder infection, but otherwise thinks clearly, thinks normally, we don't say someone has dementia, just that they're only confused during that illness, that COVID, that the pneumonia, the other sort of infection. And likewise, if someone is so depressed that they can't function well, then we don't use it, or we shouldn't use the term dementia in the setting of a significant psychiatric problem. So dementia really is a medical condition. And there's another concept or a stage of cognitive decline we call mild cognitive impairment. And this is like a milder version of dementia. So people with MCI or mild cognitive impairment also have a decline in memory or other aspects of thinking, and these problems are usually evident to the patients and family and friends. But the difference between MCI and dementia is people with mild cognitive impairment retain their abilities. They can still drive or shop, pay the bills, do the things they used to be able to do. Whereas with dementia, there is impairment or loss in these functions. Now there's some scary terms here that you'll see, especially if anyone here is over 65. But up to 10 to 20% of people who are over the age of 65 may have mild cognitive impairment. So it's very, very common. And people with MCI or MCI is a risk factor for developing dementia, Alzheimer's and forms of dementia. But not everybody who has MCI will go on to develop dementia. So sometimes things progress, but often they don't. But again, it's a very, very common stage, a very common condition over the age of 65. And I can take a few questions here and there.
Let's wait till the end, or
Wait till the
they'll
end.
go crazy, right? We're gonna wait?
I'll follow your lead.
We're gonna wait
So,
till the end for
that's,
questions.
I think, the wise thing to do. So we'll wait till the end. Thanks, Debbie. So again, dementia is an umbrella term. And dementia and MCI are symptoms. They're not diseases in and of themselves. These are just some of the conditions, the medical disorders that can cause dementia. We have FTD, or frontotemporal dementia. And I've never treated him, but they say Bruce Willis has aphasia, which is a form of FTD. There's vascular dementia, Alzheimer's, Lewy body disease, and a bunch of other things. But Alzheimer's disease in this country, and in most Western countries, is by far the most common cause of dementia, affecting, well, we'll see these numbers next. So Alzheimer's is, again, it's a type of dementia. It's a progressive degenerative disease caused by a buildup in the brain of amyloid plaques and neurofibrillary tangles. And most people who have Alzheimer's disease, especially over the age of 65 or 70, have impairment in short-term memory. There may be problems with language, behavior, and other functions, but usually over the age of 65, Alzheimer's is characterized by a significant problem with short-term memory. As I mentioned, it's the most common cause of dementia, affecting probably closer to 6 million Americans right now. And it's this slide was before COVID, but it's still the 6th leading cause of death in the US. And other kind of scary numbers, Alzheimer's affects 1 person in 9 over the age of 65, but 1 in 3 over 85. So it really is very age dependent in terms of the likelihood of developing Alzheimer's disease. 10% of people have onset of Alzheimer's before 65. We call this early onset Alzheimer's disease. And occasionally this is inherited in what we call an autosomal dominant manner, meaning grandparent, parent, siblings, and children. Every generation gets it. But that is a very uncommon form of Alzheimer's disease. So again, I've gone over these numbers already. It's a very expensive condition. The direct and indirect cost of dementia, Alzheimer's in particular, but dementia in general, is over 150, this is an old slide, over $150 billion per year. So we're talking about costs of medications, talk about cost of placement, cost of caregivers, cost of other forms of support. It's a very, very expensive condition. And as some of you in the audience may know, in caring for some of your family members and loved ones, people can easily spend over 100 hours per month caring for somebody with dementia. So it's very, very time consuming. I almost short out my computer there. What are some of the risk factors for Alzheimer's disease? Advancing age is the most powerful one. The older we get, anyone is at a higher risk for developing Alzheimer's. There is some genetic predisposition. Gender and ethnicity, it is more common in females, more common in non-Caucasians. Head injury, it has somewhat of an increased risk of Alzheimer's disease. Lower education, or perhaps in this audience, higher education is somewhat protective against the development of Alzheimer's. And risk factors such as heart disease, high blood pressure, diabetes, stroke. Any risk factor for heart disease is also a risk factor for Alzheimer's disease. And so there's a significant association. And I'll take a few questions here and there. Let me see one.
What do you mean by genetic predisposition?
So if one has several family members with Alzheimer's disease, that person has somewhat of an increased risk themselves. Yeah, one more, then we'll go on.
Well, I'm wondering if attention deficit plays a part in Alzheimer's.
Yeah, it can mimic Alzheimer's disease, but ADHD is a lifelong condition, and it probably by itself doesn't have independently a significant association with Alzheimer's. It may mimic it. Someone may be very inattentive, and they can, on top of something else, may appear to be demented, but it's probably a separate condition, separate risk factors. So there are other things out there that cause dementia. It's not just Alzheimer's disease. Vascular dementia, dementia caused by one or more strokes, is probably the second most prevalent type of dementia out there. And in medical school, we're taught that this is associated with stepwise decline. So we're normal, we have a stroke, thinking suffers, stable for a while, another stroke, so kind of a decline in a stepwise sort of manner. Lewy body disease is a very interesting type of dementia. People with LBD or Lewy body disease, and Robin Williams apparently had that. I didn't treat him either. I'm not disclosing any HIPAA anything, but he was reported to have had Lewy body disease. And these patients have very prominent visual hallucinations. I've had patients see people or animals all over the place that aren't there, all day, all night, very, very vivid, very, very prominent. Also, these patients have fluctuations in cognition. They can look pretty good one day, be very confused the next day. And also there's an interesting sleep pattern called REM behavior disorder, where people with, and that's not on this slide, but people with LBD act out their dreams. When they're asleep, they can punch and kick, and their dreams, they lose the paralysis that most of us have when we're asleep. So sleep behavior, abnormal sleep behavior is very common in Lewy body disease also. These patients have some degree of Parkinsonian features, usually not as prominent as people with Parkinson's disease though. FTD, frontotemporal dementia, is somewhat more common in the younger population. It's less common as we get older. And these patients usually have either personality changes or language changes. Bruce Willis, had aphasia, so his was more of the language form apparently. The behavior symptoms can include inappropriate remarks, come up to a stranger and say things that are inappropriate, things you wouldn't have done before, making very unwise, very inappropriate decisions, and otherwise just behaviors that aren't appropriate to the situation. And aphasia, the language problem, can be word finding, it could be non-fluency, any number of language deteriorations can represent the language form of FTD. So people with Parkinson's can also get demented. That's called Parkinson's disease dementia. Usually that happens many, many years in the course of their Parkinson's disease. Michael J. Fox has had Parkinson's for probably 30 years now, and I've seen him interviewed here and there, and he still looks pretty sharp, although his physical symptoms are pretty severe. CJD, or Creutzfeldt-Jakob disease, is very rare, which is fortunate because it's a very devastating condition. People with CJD usually pass away within a year, often within 6 months of getting their symptoms. There was an outbreak of a form of CJD in England about 15, 20 years ago associated with eating beef. And so there were, 50, 60 people who passed away in England from eating beef that was contaminated with this protein called a prion. This is considered called a prion disease. NPH, or normal pressure hydrocephalus, is caused by fluid building up in the brain. This is one of the few types of dementias that is potentially reversible with surgery. A shunt can be put in, the fluid can be drained out, decompress the brain, and people's gait and cognition can improve. And finally, Wernicke-Korsakoff syndrome. I like to put this at the end if I'm having a dinner associated with alcohol, because this is characteristically seen in people who get so many calories from alcohol, they don't get enough vitamins. They get so many calories from drinking, they don't eat the right nutrients and have thiamine deficiency and can get demented from that. Again, that's Wernicke-Korsakoff syndrome, very uncommon. And then to make things more complicated, people can have two things. People can have multiple types of dementia. We call this mixed dementia, maybe Alzheimer's and stroke, maybe Parkinson's disease and frontotemporal dementia. Again, any of these conditions we just saw can occur with other ones. Usually, though, we see it's Alzheimer's either with vascular dementia or Lewy body disease. Those all are very, very commonly occurring in the same person. So, again, not to scare the audience, in fact, this should be a little reassuring in that there are cognitive symptoms that all of us see, not uncommonly, but it's important to, I think, appreciate what's a red flag or a risk or a concern for development of dementia and what is more reassuring. So this is from the Alzheimer's Association. These are risk factors or red flags for Alzheimer's and the forms of dementia. So memory changes that disrupt daily life. If one is so forgetful that you're missing multiple appointments, missing multiple dates, recurrent significant short-term memory problems, this is worrisome. It should warrant one's consideration of seeing a physician for a memory problem. Difficulty planning and problem solving. Used to be able to plan a trip, used to be able to buy tickets to travel somewhere, losing the ability to do that sort of planning that they used to be able to do before. Losing the ability to perform tasks around the house, common routine chores, leisure activities. Again, difficulty completing things that people used to be able to do. These would be considered concerning for possibly representing early stages of dementia. Disorientation to time and place, not knowing where we are, not knowing, I'm not talking about is it 10:05 or 10:10, but thinking it's morning, and yet it's thinking it's 8 in the morning, getting up at 2 in the morning, getting dressed, getting ready to go, having a significant reversal in their body, their time clock would be a concern. Difficulty with visual images and spatial relationships, driving down the street, knowing for the past 20 years where to turn to go to the store, where to turn to go to the post office, whatever, and then losing that ability to navigate in environments where one has known for many years. Difficulty with the speaking and writing, misplacing things, losing things around the house more than they used to. Difficulty with poor judgment, withdrawing from work and social activities, changes in personality and mood. All of these can be considered worrisome signs for developing dementia. Now, before everyone goes out there and calls their doctor, because if any of these have happened once or twice, the next couple slides, I think, will hopefully reassure you as to how much of this can be seen with normal aging. And hang on, I think I dropped out one of my slides. Here we go. So, yeah, no, I'm sorry, I had a slide like, it's weird, I'm going back and forth, and sometimes it's showing, sometimes not. So what's normal? It's okay to have a hard time thinking of the right word here and there. Again, an aphasia where we're not able to come out with a full sentence, that's a worrisome sign, that's a red flag. But not remembering the name of someone you haven't seen for 20 years, that's okay. What else is okay? Misplacing things from time to time, misplacing your glasses, misplacing your remote control, finding them, not in the freezer, that would be a concern, but finding them maybe on the table where you were distracted because of the phone call. You got a phone call and just misplaced something because you were distracted by doing something else. Number 8, judgment or judgment problems. We all make decisions every now and then that others would agree with. So just because we might not do something that our families fully agree with, that's not necessarily a sign of dementia. We may be withdrawn from work and activities because we're having a neurologic problem, but we also just be tired. You know, we may be overcommitted, family, friends, and other activities, and so with being withdrawn from our life may be a symptom of depression too. So we shouldn't assume that reduction or withdrawal from life is necessarily always a sign of getting dementia. And then finally, number 10, I see this in my own, I don't think, never, I'm not going to say my own parents, but there are some people who know my parents, and so I'm not going to say anything on that one. But changes in personality and mood and more rigidity in our expectations with life happen with the normal aging process. And so a little bit of getting irritable when a routine is disrupted is not the end of the world. Can we come back to that? Because we're getting near the end, thanks. So one of my jobs when I see someone in the office with a cognitive problem is to make sure we're not missing something fixable, to make sure we don't just assume this is Alzheimer's, move on, to make sure that we're not missing something that's correctable that might be causing cognitive problems. And depression, mood problems, is one of the more common conditions that we see that can mimic dementia. In fact, there's a term for that called pseudo-dementia of depression. Depression can be so severe, people can appear to be demented. Medication reactions. I'm not going to ask for a poll from how many medicines people might be taking out there, but I've got patients who take easily 10, 15 medications. You put that many drugs in one person, huge chance of having reactions. There's no way the pharmacy computers can predict what these adverse reactions might be. So we call that polypharmacy. We need to make sure that medication interactions aren't the problem. Metabolic changes, vitamin deficiencies, or thyroid problems are common. We can check for those. We want to make sure we're not missing one of those. Brain tumor is actually very uncommon, but that's what we do, the brain scans, the CAT scans, or the MRI to make sure we're not missing a brain tumor. And it's important to also appreciate that if we lose our vision, lose our sense of hearing, if we lose both, if you can't hear and can't see, that causes significant sensory deprivation that really can cause some pretty major cognitive problems. Again, one can be confused if you can't hear what's going on, can't see what's going on, and so it's important to make sure if we can correct hearing problems, correct vision problems, we might see improvement in cognition in our loved ones. I mentioned earlier infections, pneumonia and bladder infections are very common. Dehydration is something that I see not uncommonly in my patients who maybe get depressed or for whatever reason are drinking their fluids, and that can cause a great deal of confusion too. And then finally, sometimes we pick up major kidney problems, heart disease, end-stage heart disease, severe cardiac or severe congestive heart failure. These problems can be so severe as to impair blood flow, impair oxygenation to the brain. And so it's important to make sure there's not a systemic or medical problem outside the brain that might be causing these symptoms. And now I'm paranoid the slides aren't going to go great. So yeah, so what do I do? What do I do every day when someone comes to my office? I take my history, do my cognitive examination, do examination of strength and reflexes and other things. We often order blood tests. We often order a brain scan, a CAT scan, or an MRI. And especially now with some of the newer medications that I'll talk about a little bit later, we are starting to order more spinal taps, do more genetic testing, and even do PET scans to try to confirm if someone has Alzheimer's disease or not. But what should happen with almost every visit should be a history, a physical, commonly get blood tests, and get a baseline CAT scan or an MRI of the brain. So this is a brain MRI. This is cut right through the middle. And so it's really, I think, pretty amazing the resolution that we can see in the brain with a high quality MRI. Anyone want to guess what this is? That's a tongue, very good. The tongue's pretty huge if you look at it right down through the middle. So that's the tongue, this is the cerebellum, this is the spinal cord, these are the bones in the spine, and there's the nose. What's that?
That's because she has such a big one. She's a big talker.
I'm not going to repeat that.
Tongue, big tongue.
Yeah. So moving on, this is the CAT scan. You can see how much more grainy a CAT scan is. CAT scan is basically a high-tech X-ray. It's based on X-ray principles. And the CAT scan usually should be good enough to see something that we require surgeon's help for. If there's a big tumor, a big hemorrhage, stroke that requires decompression, the CAT scan should show that. So what are the differences? An MRI has no radiation. An MRI takes longer, about 15, 30 minutes to complete. The cost is becoming comparable between the two. It used to be that people with pacemakers couldn't have an MRI. Most pacemakers now are MRI compatible, although there are some pain pumps and pain stimulators and things that are not compatible with MRI. In contrast, the CAT scan requires radiation, very quick, takes less than 30 seconds typically, and you can have pretty much anything in your body, as long as you're alive, of course, but anything in your body that will not be a problem getting a CAT scan. So what are the treatments that we have for dementia? And I want to put medicines last, because really one of the first things we need to think about in treatment is education. We need to educate family and the patients as to what's the disease, what to expect. Plan for the future is something that is important to do as early as possible if someone has a progressive disease. And so really I can't emphasize enough the importance of education and counseling when someone has a progressive neurologic disease. And then there are plenty of treatments that aren't medications that can be very helpful. If someone, for example, sees in their apartment a plant that they misperceive as a person, a scary person, well, rather than ever medicating that person, let's get rid of the plant. Let's get rid of the trigger that might be causing some of the confusion, some of the malcontent. Creativity is music therapy, art therapy is very powerful, very helpful in stimulating the mind. Attaching structure to the day, organization is again very helpful. Having a day that's every day is different and no structure, no schedule, it can be very confusing to someone who has mild stages of dementia. And then finally, behavior modification. That's sort of like we talked about earlier. If there's something that you can change in the environment or change in someone's behavior. Let's say, for example, that someone's caregiver, I don't know, wears a big hat that scares the person. They think it's a cat on their head. Well, get rid of the hat, get rid of the cat, get rid of the something that's confusing them. And otherwise, other behavior modifications. Let me think about that. So if someone walks into the dining area and always goes and picks up a vase that's got looking and throws the vase around, well, let's get rid of the vase. Let's remove the trigger to the behavior. So there's a lot that can be done short of medications to help the situation. The medications we see here, they're really not that good. They're better than nothing. Aricept, Exelon, which is often a patch, memantine or Namenda. These medications slow down the cognitive decline a little bit, but they don't really get to the root cause of the problem. They're more like Band-Aids that might slow the symptoms down a little bit. But we do have a new a new way to treat Alzheimer's disease. And we call these disease-modifying therapies. And the first drug that I think might be mentioned on the next slide that came out about 2 years ago, and then something else came out last year. So we've got some new medications for Alzheimer's. And to think about what they do, we need to remember what Alzheimer's disease is pathologically. It's a disease of amyloid plaque and tangles in the brain. And then eventually, as plaques and tangles accumulate, there's inflammation, and ultimately we lose nerve cells, we lose neurons in the brain. It's also important to remember that the symptoms of Alzheimer's disease usually start decades, literally decades, after the changes first begin, after someone has amyloid depositing in the brain. Dementia happens many, many, many years later. So we really potentially have a long time to intervene to try to address the root cause of the disease. There have been a number of drugs that have been studied over the years. Unfortunately, until recently, they've all failed. The immunizations to immunize someone against Alzheimer's disease and immunize them against amyloid plaque, those have failed. Certain antibodies have failed, other drugs have failed. Again, until the middle of 2021, we had a drug called Aduhelm or aducanumab that was approved. It's an IV drug given every 4 weeks. But the data wasn't very good. One study, there were 2 studies that were done, 2 phase 3 studies. One didn't demonstrate any benefit, the other one demonstrated marginal benefit. This drug was only approved by the FDA because it was shown to remove amyloid protein from the brain. It wasn't approved because of proof of clinical benefit. And some of you may have seen, this was all over the news about 2 or 3 years ago. In fact, Medicare rates were increased for the sole purpose of, I'm going to move this, for the expectation that this drug would be so commonly prescribed. And it was initially came out at $56,000 a year, but the fear was that with 6 million Americans, $56,000 a year, this would just be a huge stress in the system. So they increased Medicare rates as a result of expectation about what might happen. But what did happen is that doctors we didn't start prescribing it very much. Full approval never came, and just a week or 2 ago, it was announced that this drug is leaving the market at the end of this year. And so that came, and that will be leaving. But this was just the first of what I think will be several drugs for the future. The next medication, Leqembi or lecanemab, was approved last year. It is reimbursed by Medicare. Another one will probably come out in a couple of months. It's called donanemab. Also likely will be approved by Medicare. These are also infusion drugs. They're given every 2 to 4 weeks. All of these drugs remove amyloid protein from the brain, and they do so pretty well over the course of 18, 24 months or so. They delay the decline by 25 to 35%, which may not seem like a whole lot, but you can think about it in terms of someone who is treated with one of these drugs compared to someone who's not treated. If you look at the decline that someone who's untreated has, they'll decline a certain amount by a year, but the treated person will get to that same point by 18 months. So we're really looking at buying time, delaying the decline, delaying progression of disease. Now, these drugs aren't perfect. They cause changes in the brain called ARIA, bleeding and swelling in the brain. And these happen up to 40% of people who are treated depending on their genetics. Usually these symptoms are not associated with any symptoms at all, but sometimes these can be life-threatening, and there can be allergic reactions too that are usually mild. But the main thing that we worry about is this bleeding and swelling phenomenon, and so people on these drugs get numerous MRIs through the course of their treatment. And I don't know, you probably can't see this very well in the back, but this just demonstrates over here how someone who is treated with, and both drugs are similar, both lecanemab and donanemab, both of them have a more gradual decline, a less steep decline compared to the placebo arm. And so again, at 18 months, the treated people are at the point where the untreated people were at 12 months. So again, looking at a 6-month decline over the course of 18 months or so of treatment. Even more impressive, if you look over here, this demonstrates how much amyloid we see in a PET scan in the brain. And people who are not treated, have no reduction in amyloid. Amyloid stays or even increases a little bit. But on medication, the amyloid level drops significantly to the point where it might even be undetectable after 12, 18 months or so. The imaging improvement is not as impressive as a clinical improvement, but still, this is a pretty powerful change. And what we're hoping for, and I don't think I've got that here, but what we're hoping for is someday, if it may be demonstrated to identify people before they have any symptoms at all, consider treatment in asymptomatic people, and maybe have an even more powerful impact in terms of potentially preventing someone from getting dementia altogether. And that would really be a wonderful hope. And there are clinical trials going on right now for asymptomatic people. Here we go. Okay, so who's appropriate for these drugs? People with NCI or mild dementia. If someone is severely impaired, it can be too late. The medicine can be too dangerous in late-stage disease. If they have to be proven to have Alzheimer's disease, so you have to get a spinal tap or a PET scan in order to demonstrate appropriateness for treatment. A lot of reasons why these drugs might be contraindicated, though. If you have atrial fibrillation on anticoagulation, if you've got dementia from something else, if you can't have MRI, if you have a certain genetic profile that's associated with increased risk of complications. So there are a number of reasons why many people aren't appropriate, but for those who don't have any of these problems, it would be a reasonable consideration. And yeah, so it's not appropriate for people whose symptoms are either too advanced or currently have no symptoms at all. We can't prescribe this medication, for example, currently to people who are asymptomatic. So if you have concerns about yourself or your loved one, what do I recommend you do? So I would suggest before you reach out to the doctor, think about your goals of care. How aggressive do you want to be in terms of medical care? If one has a whole bunch of medical problems and the consideration of being tied to an IV table or an IV chair every 2 weeks for the rest of one's life, if there's a lot of other things going on, that may not be that appropriate. On the other hand, if someone is healthy and really wants to be very aggressive with care, these considerations can be very important in helping the physician determine what sort of path they might want to help you take. It's important also to address advanced directives as soon as possible. Then get wills done, get powers of attorney done. If you see me and I say, not you, but if we give a diagnosis of dementia to someone, it might be more difficult to appoint someone to be your power of attorney. So it really is important to get these legal affairs completed as early as possible. Bring someone with you to the doctor's appointment if possible, someone who's close to you, someone who you trust, in part because many people with dementia don't know they have a problem or don't remember they have a problem. And so I can't help you that much if no one tells me what's going on. So I need information from someone who's reliable, someone who can really fill me in as to what's going on at home. Get a medication list, include prescriptions, but also include over-the-counter medications. There are so many over-the-counters, they can have all sorts of cognitive problems. And also, don't just tell me what's prescribed, but tell me what's actually taken. Mm-hmm. So, that sometimes can be very, very different. One may not take half their medications that they're given. And write down, I would say, a short list of concerns. I've seen textbooks that are given to me, and I respect the time and effort that one puts into them, but physicians, we don't have the ability to read 20 pages prior to walking the door. If he gives a short list of concerns, that can be very helpful. And so then what you do after that, start with primary care. Primary care can hopefully identify medications that are a problem, can make sure that there aren't kidney problems, liver problems, cardiac problems that might be relevant. The primary care can hopefully address depression, anxiety that might be contributing to cognitive concerns. And primary care should be able to get the MRI done, should get blood tests done. So there's a lot that can happen before one needs to see the neurologist. But if you do need to see a specialist, consider neurology. I work with some geriatric psychiatrists. They can do a lot of the same thing in terms of the cognitive workup. Neuropsychologists are great, but they're not physicians, so they can't diagnose. So they can't treat. And they also can't order MRIs and blood tests and things. But neuropsychologists can be very helpful in getting cognitive testing done. Neurologists and other specialists, we can finish the workup, we can get the MRI, do cognitive tests, order other testing, and then we can talk about medications. And something that's very sensitive, we often are the ones to talk about safety of driving, safety of living alone, ability to manage finances and whatnot. So these are things that often have to be discussed if the problems are significant enough. So I did want to put in, just this is the last slide, I think, limitations to care. And as I've spoken to several people out there, access to care can be a problem. It can be a problem even in a big city like Austin. Underserved populations historically don't have great access to specialists, especially don't have great access to specialists of similar ethnic backgrounds. Rural areas, as might not be surprising, have fewer specialists in urban areas. But there's a huge shortage out there of physicians and other providers who are experienced in terms of dementia. There's an organization that certifies physicians, neurologists in terms of dementia. My specialty is called behavioral neurology. There are less than 30 behavioral neurology certified people in Texas. All but 3 of us are in Houston and Dallas, and 2 are in San Antonio, and there's just 1 more. And so there's a huge shortage of dementia specialists, even in Austin and in the rest of the state. What are other limitations to care? Historically, physicians felt that treatments for dementia weren't really that helpful. And so there's a bit of a nihilistic feeling and opinion towards treatment of dementia. And finally, as I mentioned earlier, many patients either fear dementia diagnosis, which is reasonable, or don't realize they have a problem. But it's important really to get an early diagnosis because we can do so much more the earlier something is caught. Patients can be more involved in their decision-making, involved in their care early on. And so it really is important to try to get a diagnosis as early as possible. And so I'll just leave it here. Alzheimer's Association has a lot of resources. They've got support helplines and references and resources and things. And so do consider reaching out to the Alzheimer's Association if anyone has any questions. And I'll leave it at that. So thank you, Debbie, and thanks everyone.
Thank you so much. We can only take a few questions, just a few general questions.
What? Did you tell me or somebody?
I'm wondering what experience you've had with a drug called rivastigmine, and if that's been shown to be effective.
Yeah, so rivastigmine has been available, has been approved for a number of years. It is similar to Aricept in terms of how effective it is. It helps a little bit. I prescribe it not uncommonly. It has, especially the rivastigmine patch, has fewer side effects than Aricept or donepezil. So it's okay, but it's not great. And we had a question over here that I terminated earlier.
Thank you. I have read somewhere that in terms of preventative measures, that exercise is a good preventative to prevent Alzheimer's dementia. Is that accurate?
It's probably accurate, yes. The broad answer is what's good for the heart is good for the brain. And so a well-balanced diet, Mediterranean diet, heart-healthy diet, exercise, these are all probably useful, especially in conjunction with other healthy behaviors to lower the chances of getting dementia. I think once somebody has dementia, I don't think all the exercise in the world is going to make it go away. But especially as early as possible, maintaining or initiating and maintaining healthy lifestyle, including exercise, as early as possible. It probably does delay the onset, and some people might prevent from happening altogether. Yes?
If one of the new drugs is effective at reducing the plaques, but does not really make a change in the behavior or cognition of the patient, is it possible that the plaques are not the problem?
So that's a great question, and plaques are probably not the problem. I would agree with that. We know that people with Alzheimer's have plaques and tangles. The tangles are much more associated with symptoms than are the plaques. But it does appear probable the plaques come first. It appears probable the plaques either initiate or perpetuate or increase the accumulation of tangles. And so I kind of compare it to a forest fire. The plaques are like the kindling, the dead wood, and the tangles are the flames. You can have a fire that's burning in the forest, and you can get rid of all the brush and tangle and kindling, the fire's going to continue. But the fire will probably spread more slowly if you take away all the fuel to the fire. And so there's still a lot that they need to figure out, and this is probably why these infusions will never cure Alzheimer's unless you catch the disease before someone has tangles. If you catch the disease, if you remove the kindling from the fire before you have a fire, then you might be able to prevent the disease from happening. But once someone is symptomatic, then I think that's true, that all of these infusions available are not going to ultimately stop the disease.
Thank you so much. We are so grateful that you were able to come and be with us and spend some time, and thank you.
Thank you, Debbie.